Well, thank you very much for this invitation. I feel very honored to be in Oman and in the Middle East with you. Uh, I did some reading about Oman to prepare for this visit and am really taken by the wonderful history, the trade history of Oman and the varied geography. And I even learned about frankincense. And I understand that your healthcare has just undergone an amazing transformation. Uh, and I like the idea that you are really hanging on to your history and your tradition, which is just wonderful. So I deeply appreciate the opportunity to be with you. So here is our subject, and I'm just going to plunge right in. Um, the just so that you know, kind of about Bastian Voice Institute. Let me just go back. It's here. You are in Oman. I am in the suburbs of Chicago, off of Lake Michigan here. This is my building, and this is where my offices are right here, Bastian Voice Institute. And we are four clinicians, myself and two physician, Dr. Richardson and Hosley, and a physician assistant. And so that is our clinical group. And I want to just mention right off the bat that this is our current number of people with R-CPD, 2,423 as a group. My personal number is probably about 1,400. Why do I mention that? I mention that because that is primarily what I'm bringing to you. I'm bringing to you that sort of experience. I'm not really going to bring a lot of this over here to the right. So I have learned in my career that there are doctors who are simplifiers and there are doctors who are complexifiers. We need both. We need uh, we need physician scientists, but we also need physician clinicians. And I am very much over on the physician clinician side. I did have an academic career for 20 years, and so I understand this whole approach. And this needs to be a part of R-CPD, but what I'm going to share with you here is primarily about the patient. So it's patient-centric, not test-centric, and that will disappoint some people whose mental setup is really oriented towards detail and tests and proof and all of that. So we're going to stay with the patient. We're going to define the syndrome. We're going to talk about the office examination, Botox injection as both a diagnostic test and treatment, and then say to you that we don't believe the necessity of any testing unless unless the disorder is of recent onset, then we need to do some testing. But if this is a lifelong condition, there is no need for testing. We simply go with the syndrome, and that could be controversial. So I want to say that right off the bat. And we're all different. Everyone's got a different take on everything. And I'm completely okay with that. But I just need you to know that this is where I'm coming from. All right. Um, and if you want to know a little bit more about this idea of two doctors facing the very same patient may approach the patient in very different ways based on their setup, their intellectual profile. You can look at this video on conation, and it explains that idea of how different doctors do different things for the very same problem. Um, Now, for background, after we're finished today, there is a place you can go called Laryngopedia. It is an online encyclopedia. It's a public service site. And if you just go in and type in R-CPD, or I think you leave the hyphen out, and then this comes up. You click on this site and you come up with this very large page. It even has a table of contents. What is it? The top four symptoms, less common symptoms, what causes it, the treatment, where, uh, photo essays, x-rays, videos. So it's a very large web page in case you want to read more. Okay, so what is R-CPD? Retrograde Cricopharyngeus Dysfunction. The cricopharyngeus is essentially the same as the upper esophageal sphincter. It's a little more complicated than that, but I'm a simplifier, so I say essentially the UES and the cricopharyngeus muscle are more or less synonyms. And so it's a disorder of the UES or of the cricopharyngeus muscle. And it's a sphincter muscle. It's a circular muscle, and this is for the medical students. So a sphincter muscle is a circular ring of muscle that regulates entrance and exit through a passage. So for an example, the iris of the eye is a sphincter muscle. It regulates the passage of light in and out of the eye. So that is a sphincter muscle. Even the orbicularis oris is a sphincter muscle. The little toddler here can say, "You want me to put carrots in my mouth?" No, and so he can control the passage of the carrots into his mouth because he's got this circular muscle that controls passage through. And in the GI tract, we have several sphincters. We have not only the lips, but we have the UES, the cricopharyngeus muscle, the lower esophageal sphincter, pyloric sphincter. Cecum is a quasi-sphincter, and then, of course, the anus. And all of the sphincters in the GI tract work primarily, their function is primarily antegrade. So for swallowing, for passage of food and drink and saliva and liquid and saliva. So we tend to think of those sphincters as having primarily an antegrade function. And just to show you here in the hypopharynx, you see blue applesauce is waiting for that sphincter to open. Here you see a picture over here of the sphincter. This is the esophageal opening right here, but this is the cricopharyngeus muscle. This is our culprit. Here you see another picture showing that cricopharyngeus muscle, and here is the opening of the esophagus at the star. Here we've turned the picture upside down, and here's how you see the sphincter muscle during endoscopy. And here you see a little needle giving that sphincter muscle, and we'll get to that again later. But I just want to establish that this is the sphincter we're talking about. So if we look radiographically, antegrade cricopharyngeus dysfunction, you're all familiar with. That's a swallowing disorder. And you see the reason for the swallowing disorder is remember I said a sphincter can control the entrance through. And so this sphincter muscle here on the left is not relaxing. And so we have a wide river, we have a little stream. So there's this narrow place, and then we have the wide river again. So this is antegrade dysfunction. The barium is being impeded by this narrow place right here. That's antegrade. And here, after cricopharyngeus myotomy, right here, you see we again have the wide passageway. Here is another picture showing little zincers, incipient zincers, and the thumb of the muscle becomes progressively more and more of a finger. It turns upright, and as the sac is formed here. But the culprit here is the muscle. So the two of the sphincters in the GI tract must also work retrograde. So if a person needs to vomit, this sphincter has to be able to let go in a retrograde direction to let us put food or contents up in order to vomit. This sphincter, the cricopharyngeus muscle, also needs to be able to work in the retrograde direction in order to permit, pardon me, in order to permit burping or vomiting. But here's the key. In R-CPD, the UES will not release in the retrograde direction. And then we get what patients call the no burp syndrome, I can't burp, or R-CPD. And so when this sphincter will not let go to let us burp or vomit, there's a backup all down the GI tract, and the symptoms are primarily GI. And so patients typically present to general medicine and gastroenterology because the symptoms are predominantly GI. But the problem is kind of ENT. And I know that there's a debate. Is this a GI responsibility? Is it an ENT responsibility? And I personally think, for a variety of reasons, that it's a GI maybe diagnosis, but we are better equipped, I would posit. And again, there would be a debate about that, which I'm perfectly fine with. The point is, whoever takes this seriously and takes this caseload in and helps them, that's the person who should be in charge of this. Now, for a sphincter to work, it means to let go. And so these two sphincters have to let go to let us vomit and burp. And there is a continental divide, which is the pyloric sphincter. The continental divide in the United States, the Rocky Mountains, the rain that falls on the Rocky Mountains, it goes to the west, mainly through the Colorado River. It goes to the east, primarily through the Mississippi River. So it's a continental divide of where rain goes. Well, here, the continental divide of where air goes is the pyloric sphincter. So anything above the pyloric sphincter can be released as burping. Once air gets below the pyloric sphincter, it must be released as flatulence. So those are the only two ways we can get rid of GI air. Burping, pyloric sphincter up; flatulence, pyloric sphincter down. So there we see it. Now the upper esophageal sphincter, I'm going to go through there. Imagine this as air right here, this blue, and the sphincter won't let go. Then what happens is the esophagus begins to dilate, the stomach begins to dilate because we're putting air in, air in, air in, air in, but we can't ever get it out. And so it accumulates, it dilates the esophagus. This is a typical picture. This is an office picture. When we do our examination, we give them blue applesauce, an orange cracker, blue water, and then at the end, I have them swallow a gulp of blue water. I follow the water down into the esophagus, and this is the picture I get routinely. You see what I call the tracheal mound, right here, tracheal mound. This is the aortic shelf, I call it, the aortic shelf. In the darkness, you can see the left main stem bronchus here. But my point is that the esophagus is a collapsed muscular tube. It isn't an open, always open. The trachea is an always open structure. It's held open by tracheal ring. It's an always open structure. The esophagus is a collapsed muscular tube that relaxes perfectly to let food and liquid through, but it doesn't typically stay in an always open position, except in this group. Sometimes in elderly people, you'll see a patulous esophagus that's kind of always open, but this is a classic finding. So in a muscular young 18-year-old football player, this is a common view. And notice that the walls of the esophagus are smooth. It's not in ruffles or ridges, which you would see if it were partially. It's fully stretched and contracted. And you can see you can't compress the trachea, you can't compress the spine. And so the stretch tends to be lateral. And that's the source of some of the chest symptoms, which we'll get to. And these are all classic esophageal findings. I showed you the tracheal mound. Here's the aorta. Here's the tracheal mound in a different person. That's the left main stem bronchus right there. Here's the aorta again. These are three different people. This is someone, must be an older person with a little spine arthritis. Here's the trachea. And this shows it particularly nicely how the stretch has to go laterally because you can't compress posteriorly or anteriorly. Well, the downstream effects of inability to burp are terrible. And by the way, there are people who say, well, this is just an aerophagia. It's a psychogenic. It is not psychogenic. These people, they sense the need to burp and it makes them uncomfortable. And they're trying to, and what do people do when they are uncomfortable? They swallow more. And every human swallow, all of you listening, if you swallow, I'll swallow a little bit of air accompanied what I swallowed. And so that little bit of air is typically seen as a small gastric bubble right here. And if that gastric bubble gets too large, then we burp. But notice this person, a huge dilation of his stomach. Huge. This is the stomach. This is air in the transverse colon here. And here is air in the descending colon. So we get gurgling. This explains all of the symptoms. We get gurgling noises. We get bloating. The stomach distends very often. We get painful hiccups. We get nausea. We get acid reflux because imagine all of this pressure, back pressure against the lower esophageal sphincter. And then finally, we get flatulence and constipation and diarrhea. So it's remarkable the number of symptoms. And this KUB X-ray is not a necessary part of the workup. But if you talk to people with R-CPD, many of them will say, well, yeah, one time I went and I was going to have my tonsils out, or I had a chest X-ray, or I was having abdominal pain. I went to the ER. So people get X-rays for a variety of reasons. Yeah, or I went to my chiropractor and they did an X-ray and they said, oh my goodness, you are so full of air. So there are a lot of people who have get an X-ray for incidental reasons, and these findings are seen. Pardon me, I it's early morning here, so my throat is still waking up. Now, um, all of this adds up to daily misery. So this is the same patient. And notice I've got the arrow to the little nevus here. And you see there it is. And I'm showing you that to prove to you this is the same person. And it's across one day. So it looks like this person has gained a huge amount of weight. Pardon me. But in fact, this is the same person. Uh, this is what she looks like late in the day. This is what she looks like early in the morning. So, pardon me, in the evening, she begins passing a tremendous amount of gas. Even all through the night, she's passing gas. And, and sorry, just looking for something here. She's passing gas and then she's flat in the morning. End of day, she does this every day back and forth. So that's the kind of, I'm so sorry. Now, here's the normal air bubble, and here's the kind of air bubble you see. Do you see the lifted diaphragm? And that partly explains the one of the symptoms, which is a feeling of shortness of breath. It's not being out of breath, but people say, I get so full that I want to take a deep breath. And so I kind of go to take that deep breath, and I can't finish the deep breath because I'm so full. And you see with the elevated diaphragm why that is, why they get that feeling of, I just can't finish a deep breath. Um, so um, the shortness of breath, here is what I call abdominal crisis. This is a young man who has terrible R-CPD and he has a lot of constipation with it. And so he got angry one evening and he took a lot of magnesium citrate, which is a carbonated laxative. And this is his stomach. Remarkable that he didn't rupture his stomach. Here you see some of his colon pushed way up to the side, and here's more of the colon. And so he had to go to an emergency room, get an NG tube, and so this isn't super common, but I've run across in my 1,400 patients or so, about five who've had this kind of abdominal crisis, maybe more than that. Well, the index case was in 2015, and he sent me an email to Laryngopedia describing his no burp before it was codified or treated. He had been to GI doctors, I think a couple of or three in Texas, and he said, I said, you need to get someone to inject Botox. And my thinking then was that this was for diagnostic reasons. I didn't see it at that time as a treatment. I saw it as a temporary treatment, but I assumed that people would have to be re-injected a couple or three times a year or have a myotomy. His emphatic reply was, I'm coming to BVI. I said, you don't need to. There are a lot of people in your area who could do this. He said, I'm so tired of all of the doctors that I've worked with that I'm coming to Chicago. And the result was he got permanent relief from a single injection. He went to Reddit, an online message board, YouTube, Facebook articles, and the people began to trickle in. And so um, finally, I said, I better look it up. And I found only three case reports, none of them really codified. So they just said, we have a patient who can't burp and has incapacitating chest pain. And they did some thinking about it and they said, maybe to put an NG tube in, maybe do this. But nobody had a solution. Each of these three had a single case report and they didn't codify and no solution. So I decided I'd better write it up. So after getting to about 200 patients, I took the first 51 because I had long-term follow-up on them, and I published this initial article, and that is found on Laryngopedia. These are all open source, so you don't need a subscription. You just go to Laryngopedia, and you can find these 5 articles. And other people around the world are also now publishing uh, nice articles on um, this subject. So here's the where you can get that first article: inability to belch and associated symptoms due to retrograde cricopharyngeus dysfunction. So that's the original description that created it. So what had failed in our 2,400 patients? What had failed to deliver a diagnosis? Complexification had failed. So these people had done office visits, they'd seen GI doctors, barium swallows, EGD, pH probe, manometry, stool cultures, bolus scintigraphy, colonoscopy. They'd done all of that kind of thing. We did not have one person who got the diagnosis. So 2,400 people, probably 10 or 15,000 major tests, diagnostic rate 0, not one diagnosis. Well, what does deliver the diagnosis? Simplification, syndrome recognition. Can't burp or can't burp adequately. Some of them do little micro burps. And it's lifelong, excluding infancy. They say, as long as I can remember, I don't remember ever being able to burp. Yeah, it's true. A micro burp here or there, but they don't relieve my symptoms. Gurgling is almost universal, probably 92%. And it's gurgling that's from here. It's not hunger pain, kind of growling of the stomach. It's a gurgling, it's croaking frogs. It's mostly, they say it's from here. And if they open their mouths, it becomes much louder and can be very, very uh, embarrassing in public. Bloating, and bloating is thought of as an abdominal symptom, but I've come to think of bloating as being abdomen primarily, but also chest pressure and low neck. So a lot of them have 3 levels. And extreme flatulence. Those are the big four. And Sir William Osler is a very famous physician from 100 years ago or 150 years ago here in this country. And he's the one who said, if you talk to the patient, he will tell you what's wrong with him. And that's the case here. If you just talk to these patients, they will tell you, I have R-CPD. I can't burp. I gurgle. I bloat. I have tremendous flatulence. But there are some other symptoms. Oh, by the way, tailored manometry will confirm. So there are some, I think there's another study that was published recently showing R-CPD manometrically, showing and standard high resolution manometry will not give you the diagnosis. You have to tailor it. You have to give people carbonation and focus on the pressures in the esophagus and at the upper esophageal sphincter. So this is the first article that I know of with the four here that showed manometrically that people can't burp. But my point there is, so you do manometry, you prove that the upper esophageal sphincter won't let go, and you as a doctor turn to the patient and say, "Oh my goodness, did you know you can't burp?" And the patient says, "But that's what I've been telling you." And so the dilemma is that there are places where people say, "Well, you must prove the diagnosis with manometry," and I have no problem with that. But I would just point out, I really don't think it's necessary. It's a nasty test if you've ever done or seen manometry. It's not a pleasant test. It's very expensive. And for what purpose? So high fact finder doctors will say, "Oh no, we must make this scientific. It must have a," and low fact finder doctors, that's the conation I showed you at the beginning, will say, "No, you can proceed based in the patient's story. I can't burp, I gurgle, I have bloating, I have flatulence." And by the way, um, what were the prior diagnoses that were given to these 2,400 patients? Well, they were told they had GERD. Fair enough. You can imagine why a lot of them do have GERD, but it's not the main thing. It's the result. Irritable bowel syndrome, because they get sometimes diarrhea or they get constipation. Well, but if you stretch the colon way out of shape, doesn't it stand to reason that it won't work very well to evacuate stool? Slow motility, that's another thing. So people were told, "Oh, your problem is that your esophagus doesn't contract very well." Well, you take an esophagus and you stretch it out of shape, and doesn't it stand to reason that motility may become altered? Small intestine bacterial overgrowth. I made a whole video on why I think that might be the case in some. So these are the things that they were diagnosed with, but they were treated for all of those things and they got zero relief other than their reflux. I can manage my reflux. So, um, what does can't burp mean? It means I never burped in my memory. So there's a subset of people who say, "Doctor, I honestly, I don't think ever once in my life I have burped." So there's a small group that say that. More commonly, it's what we might call burping insufficiency. I remember a patient who said, "Doctor, I have burped 4 times in my entire life. I remember where I was and what I was doing each time, 4 times." Then there are people who say, "I have to air vomit. I take a toothbrush or I stick my fingers down and I do this heaving and retching, and then I make this massive noise. We call it let the devil out. That's called air vomiting." And so in a sense, that's burping, but it's a not a true burp. It's an induced massive burp. And then a lot of them say, "Well, I do have these micro burps, sometimes I'm not expecting it. I never know it's going to happen, but suddenly there's this little burp and it's like I jump and it happens a few times a year, or we even have a few people who say a few times a month, I have these little micro burps, but they're not relieving. I don't know how to harness them. They don't give me any benefit." So the cardinal symptoms I've told you: can't burp, gurgling, bloating, and distension, flatulence. Other symptoms: nausea, especially after eating, and occasionally that's the main symptom for some people. Hiccups that hurt. In the general population, hiccups do not hurt. But in this population, typically they get hiccups and sometimes they're excruciating. Hypersalivation, like when you're about to vomit and you sort of begin to drool. These people, some of them have that kind of problem because they're so uncomfortable. And then they say, "I hypersalivate and I swallow more." That mechanical shortness of breath. Emetophobia, fear of vomiting, is major in this population. It's about 1 out of 3. It's about 1 out of 1,000 in the general population and 1 out of 3 in people with R-CPD. Constipation. We even have people who become so dilated and distended that they begin to have a rapid heartbeat and flushing, and we don't know if that's an autonomic response or if it's a fear response. Um, and so my maybe bombastic, maybe this is a little too strong, but what I tend to say to people is if you fit the syndrome of R-CPD, all GI symptoms are due to R-CPD until proven otherwise. So treat the R-CPD, don't chase the constipation, don't chase the GERD. I mean, treat them as you can, but don't chase them as the main thing. Treat the R-CPD and then see what remains. So when people search online to find what's wrong with them, they may go to the internet and search on flatulence because they were in a social circumstance and they embarrassed themselves. So they go search on flatulence. Somebody else may say, "Oh, every time I eat, I'm nauseated. I'm underweight. I have to stop eating because I just feel so full and nauseated." So they have gone to the internet to search nausea, or that may be the symptom they bring to their physician. And or someone else, it may be the shortness of breath. We've had people treated for asthma because of that shortness of breath kind of thing. And so my point is that if the diagnosis is suspected, you validate the syndrome, and we have a questionnaire. Happy to share that questionnaire with you. So the patient fills out a questionnaire, and once you look at the questionnaire, it's like it's obvious this person has R-CPD. And then we do an examination because if we're going to the operating room, we want to know something about their jaw, we want to know about the base of tongue and so forth. And then because it's so easy to do, we always do that little mini esophagoscopy. And it's just with a little ENT scope because they're already dilated with air. You don't need an air channel, you don't need a compressor. You just kind of jump in with a swallow of water. And there you see this always open esophagus. Then you inject Botox, and I have experience with all these different dose levels. And you can go to the operating room or you can do it with EMG. And then you make sure the patient practices. So that's the clinical sequence. You just meet the patient, talk to them, let them tell you about their symptoms. You say, boy, that is the total picture of R-CPD. You do an office exam, then you go to the OR or in the office do a EMG injection. That's the sequence. Now, how to inject it? I showed you this picture earlier. You don't use a esophagoscope. You don't use the bivalve Weirda type scope. It's not a scope that you would use for Zenkers. Instead, you're using a laryngoscope. So the laryngoscope is far easier. And we have the Zytels, the modular scopes. You can extend the slider to make it a little longer, or we also have a Dido. There's a long Dido scope for the very tall male person that's hard to reach. And then we use a butterfly. So you take a butterfly and you cut the wings off. You leave a little nubbin on one side to hold on to with a straight alligator. So, and then the tubing is long enough to come out, and then your syringe is attached out here. So that's the way you do it. I usually inject in 2 or 3 places. You don't want to pass point, go too deep. If the sometimes it's almost like a membrane. It's like some people have very little bulk to their muscle, and there are some who have quite a bulge, and you don't see the muscle until you lift the larynx. As you lift the larynx, you see. Some people have a lot of overlying mucosal redundancy. It's like what I say, injecting through a shower curtain. And so you're in this case, this middle picture, you're going to need to use palpation a little bit more to figure out where that muscle is. And then the EMG, I should have some pictures of this, but it's really very simple. At the level of the inferior border of the cricoid, you're injecting from the side. So you're injecting through the anterior SCM muscle, and you're going, and I usually uh, engage the back end of the larynx, and I bounce on a little bit, and I can see the larynx moving, and then I move slightly posteriorly and get into the cricopharyngeus muscle. And the other way to do it is to come anteriorly through the cricothyroid membrane. You go right through the posterior plate of the cricoid the inferior part and into the muscle beyond, and you use sniff to make sure you're not in the PCA muscle. I'm trying to refine my technique. I am now doing exclusively EMG, and my two partners are doing exclusively OR. So I'm getting about an 85% success rate with the EMG, and we get about 95 in the operating room. But of course, EMG is much simpler, so a lot of people prefer it. Well, the EMG people get three sensations: sharp, they get pressure when you're injecting. They're sitting there in the chair saying, "Ooh, ooh, that pressure, pressure." And then some of them get a sensation in the ear, the shoulder, down to the chest. And it's very doable. I did a 13-year-old, when was that? Last Thursday, I think it was. I did a 13-year-old. So the results, this is from the first article. These are people who can't burp. 51 out of 51 said they couldn't burp. After Botox, all of them could burp. And at 6 months or longer, we had some who recurred, but many of them kept burping forever. The original patient is now 10, 11 years out and still burping beautifully. So why is that, by the way? Um, you can look at these in the articles. The point is, it's extremely effective. And what we think of is that Botox serves as training wheels for burping. In other words, the the thousand burps that they get with the help of Botox, they commune with the sensation of needing to burp, and they work the what I call the fidget. They turn their head, they thrust the chin, they look up, they tuck the chin, and the big one is they lower the larynx. So they feel the air coming and they kind of, and I've even had some people use their finger on the thyroid notch to kind of depress the larynx. They have to relax the throat and see if they can figure out how do they release the burp. And 4 out of 5 figure out how to burp and burp permanently based in a single injection. And then there are those who need a second or a third or a fourth injection. So this is from my EMR. I just copied and pasted, spoke to the patient, 4 years follow-up for Botox injection. He is still burping, gurgling, bloating, flatulence have all diminished. He mentioned non-existent. When asked about small, medium, large improvement in symptoms, he answered large. He also mentioned that the procedure has been 100% successful for me and that he feels perfectly normal. He concluded that he is very happy to be the first person to have this done and be part of this experience altogether. He is elated about your success. So that's patient number one. He's now 11 years. Here, though, here's another uh, kind of result. So you know not everyone is perfect. Um, Still able to burp, gurgling, bloating, and flatulence are gone. Symptoms continue to be 0 out of 7, large improvement. He still struggles with the heartburn and manages this okay with diet. He said this does run in his family, so he attributes it to that. We'll plan to follow up with him at 2 years. He appreciated the call. Here is a 60-year-old. Are you able to burp? Yes, but the frequency has diminished greatly over the last 30 days. This is at 4.5 months. Is the gurgling gone? I was never a big gurgler, so this has not really changed. Is the bloating gone? The bloating was completely gone, and I would say it is now greatly diminished. Is the flatulence gone? Or it's about the same, still primary way to get rid of gas. I was seeing a huge difference in my symptoms initially. My swallowing has gotten completely back to normal because they have a little weird swallowing. Burping less, really have to force them out. So you see, this is someone who is recurring, but then she is 60 years old. So the median age for one and done is 25. The median age for recurrence is 35. But even the older age group are more likely to burp forever than to recur, but they're a little bit more likely to recur. So summary, it's misery, but it's an easily recognized disorder, prima facie on the face of it. You do not need testing by the syndrome. This is my recommendation. You know, where I am, medical resources are not endless. There are limitations. And so why use medical resources to do testing and um, so keep the clinical process simple to avoid medical jadedness. There's an article on Laryngopedia that is called, I think it's about sensory neuropathic cough, where I coined the term medical jadedness. Those are people who say, doctor, they may not say it to you, but it's behind their eyes. They're thinking it. So if you ever walk into a room and a patient seems hostile right off the bat, or they seem skeptical, they're probably medically jaded. They have gone to many doctor visits. They've complied with everything they were asked to do, and they got nothing out of it. And that is often the case with R-CPD. My record is a patient who saw 13 different GI doctors, 1, 3, 13. And so when a person does that kind of work and expense and misery, and they come to you, and now you're sort of the bad guy even before you have a chance to talk to them because they are medically jaded. And that's why one of the reasons why I'm on the side of simplification, not complexification. So, and by the way, the 1,400 people that I have personally seen, 2,400 in our group, not one of them was wrong. Well, actually, I take that back. I have two people who came. One came who simply didn't pay attention. I don't know why he thought he had R-CPD because when I asked him the questions, he didn't match anything. And so that's one outlier. And another one developed it after pregnancy. And she came saying she realized she wasn't typical and her symptoms were a little bit off. So, with those two exceptions, the patients came to me. In fact, they'll fly here from California and I'll have them scheduled for the procedure. And why would I let someone fly all the way here just to be wrong? And they came here for nothing. That's how good patients are at matching themselves to this syndrome. So my point is, if patients can diagnose themselves 100% accurately, then physicians can do the same. So just validate their self-diagnosis and inject the Botox and make sure they practice, practice, practice. So what does it mean? You explain that they're going to get spontaneous burps from the Botox. The Botox is doing all of the work. Then you say, okay, Botox is really doing the work for you, but I want you to fiddle with the burp. I want you to kind of crane and do various things and squeeze your abdomen and see if you can, what you can do to make the burp happen a half a second before it would have if you had just sat passively letting the Botox do everything. You're looking for the hook, the little, all of you listening, if you analyze your own burps, you will discover that the burp arrives ready to release, but you have a choice whether you want to release it or not. If you're sitting next to a world famous person, you can choose to just kind of wait. And you also have that little release. There's this little thing you do. For me, it's a slight lowering of the larynx, and that releases the burp. And that's what these people have to look for. So Joe burps alone, then at the end, using the hook that he's been taught by the 1,000 burps that Botox gave him. And you use carbonation once you're burping post-Botox. Controversy is who should diagnose and treat. I mentioned that earlier. It can be GI, it can be, I actually don't care who does it. I just want patients to get relief from this terrible disorder. So it seems to me, and I am a laryngologist, but it seems to me that our technology, our scopes, and our EMG experience suits us a little better. I thought it would be kind of complicated to use a flexible scope in the upper GI, certainly the lower sphincter, they would be the ones, but it seems awkward to me to use a big GI scope for the cricopharyngeus muscle. But I'm sure there are GI doctors who can figure this out and get very good at it. And I say, go for it. Thank you. Um, so controversy, who should diagnose and treat? I think it's our specialty, but I'm open to whatever. Any test needed, and I am in touch with people who are these high fact finder, complexifier mindsets, physicians, scientists who are just adamant that we must do manometry and we must prove for every individual, we have to prove it. And so, whatever I say, whatever, we're all different, different strokes for different folks. But my personal view is you don't need any testing when the person says, I've never been able to burp. If they say this developed last year, then yeah, you need some testing for sure. But, oh, and by the way, I forgot to say, when you ask people, when did this start? They will often say, oh, I was 15. But what they're describing is that's when the syndrome, that's when the symptoms began. So you must always say, could you burp before that? And they'll say, no, no, I never could burp, but it wasn't really a problem. So the true R-CPD patient is almost always lifelong. Now that excludes infancy because 2 out of 3 where you have history, you don't have history in a lot of them, but 2 out of 3 who have knowledge of their infancy through their parents say, yeah, no, my mother said I did burp as a baby. So when I use the word lifelong, I mean the person's memory. Have you been able to burp that you remember? And they'll say no, other than those micro burps. Which technique, endoscopy versus EMG, that's going to be your choice. The dose, my first 200 were 50 units, and it worked extremely well. Why did I go to 75? Because I had a couple who it didn't seem to be enough for. And so I said, well, I'm going to overtreat a lot of people in order to capture a couple of people who actually do need the pretty high dose. Then I moved to 100 because I said, well, these people are flying here from all over the place and they have to buy the entire vial and it's 100 units in the vial. I'm just going to put the whole 100 units in there and I'm going to recognize that I'm going to give a fair number of people more slow swallow, that sort of hanging food and liquid in order to capture the maximum number of people. So most people's 100 is plenty. It's really more than they need. So when to perform myotomy, my personal rule is unless a person has had 3 injections that worked well, I don't really want to do a myotomy because it's a deal. It's a terrible sore throat and it's a surgical procedure. And you do have people who say, yeah, after the first shot, I got great relief. And at about 2.5 months, I started having trouble. And then I kind of lost it by 3 months. Then they'll say, after the second injection, I went 5 months and then I kind of lost it. And then after the third injection, I went 9 months before I lost it. So you see, there can be this additive benefit, but myotomy is an option. But I don't like myotomy when a person says, oh, I've had 3 injections and they didn't work, so I'm ready for a myotomy. I want 3 injections that did work before I'm interested in doing a myotomy. Surgical anatomy, we have these people right here, these people. And so in our place, we have a series of scopes. We have the Hollinger, the Jackson, the Hollinger, the slider scope of Zeitel's. We have a Dito Ossoff, the longer length. We even have the weirdest scope, which I think I've used once. So you need a small scope, and the small scope, unfortunately, you're injecting monocularly. All the rest of the scopes, you're using the surgical microscope to view so that you can see the accuracy of your injection. And somebody like this might be told, you really should consider an EMG approach to this. I have had one perforation, and one of my colleagues has had a perforation, my hardest patient, and it was before I was doing EMG. And but it was a person like this and worse. She's like the worst I think I've ever seen in my entire career. Um, Now, what about infants and young children? I've got a little article on Laryngopedia, babies who cannot burp and still cannot as adults. My baby can't burp. This is a 2-year-old, I think, with R-CPD. And so that group, we want to identify and treat people with R-CPD as young as possible to save them the years of misery, the embarrassment when they're in high school and they're gurgling during a test and people are looking around and they're having all this flatulence. And so, um, so anyway, here's how I do the myotomy. This is a picture I'm sure you've all seen. Okay, I think that is the main subject. Now, I'm happy to take questions, and I should have mentioned something about slow swallow, so let me explain that. Slow swallow, I explain to patients that the sphincter muscle is